Hi class, this presentation will be about Guillain-Barre syndrome. Within the presentation, we will be talking about the definition and etiology, pathophysiology, signs and symptoms, incidence rate, method of diagnosis, subtypes of GBS or Guillain-Barre syndrome, therapeutic management, and prognosis. What is Guillain-Barre syndrome? It's a neurological and inflammatory disorder in which the body's immune system mistakenly attacks parts of the peripheral nervous system. As we know, that is the nerves located outside of the brain and the spinal cord. Guillain-Barre syndrome is also known as acute idiopathic polyneuropathy or polyradiculoneuropathy. The peripheral nerves send motor and sensory signals to and from the CNS, the brain, and the spinal cord. They are covered in myelin sheath, which is right here, and comprised of cells called the Schwann cells, which promote better conduction of the signals. With Guillain-Barre syndrome, the demyelination of the Schwann cells results in damage to the peripheral nerves and affecting the way signals are sent. In this picture right here, we can see a normal sensory or motor nerve, and here we can see how the fiber has been exposed, the myelin has been damaged after or affected by the Guillain-Barre syndrome. Etiology. The exact cause of Guillain-Barre syndrome is not well known. However, we do know it's an autoimmune disease and it can be triggered by different factors. One of them can be a viral or bacterial infections with organisms as the ones in these pictures, the Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, and Mycoplasma pneumoniae. It can also be triggered by vaccinations as the flu, rabies, and meningitis vaccines. It can be triggered by surgeries and respiratory and gastrointestinal infections. Now we're going to move into the pathophysiology of Guillain-Barre syndrome. So the B cell, which is the immune system, makes the antibodies that are needed to destroy any viruses or bacteria. In this case, we have the Campylobacter right here. So the antibodies travel all the way to the virus or the bacteria, attaches to it in order to destroy it. But at the same time, some antibodies might go straight to the sensory or the motor nerve, attaching to the nerve, and it damages the nerve cells. Now we can talk about some signs and symptoms of Guillain-Barre syndrome. So the first signs of Guillain-Barre syndrome are often ascending and symmetrical weakness or tingling in your legs. So usually it starts on the lower extremities. You can also expect neuropathic pain, peripheral loss of sensation, decreased tendon reflexes, and as Guillain-Barre syndrome travels all the way up, it can affect your respiratory system, and it can go all the way up to your cranial nerves right here, and it can affect your eyes, your nose, your mouth, even your throat muscles. So now we're going to talk about the incidence rate. 1 in 4 cases per 100,000 individuals per year. Men are more likely to have or to be affected by GBS more than women, and usually older than 50. However, women are affected by GBS. No evidence exists of any racial predilection. It is one of the most common causes of non-traumatic paralysis in the West world. And 2 out of 3 patients have had a history of gastrointestinal and/or respiratory infections. Method of diagnosis. We have 3 main ones. The first one they usually start with, it's a good medical history. which is to find recent viral infections, recent onset within days to at most 4 weeks of symmetrical ascending weakness starting at the lower extremities, as absent or diminished deep tendon reflexes, abnormal sensations such as pain, numbness, tingling in the feet. The second one is the nerve conduction velocity test, and the purpose is to measure the nerve's ability to send signals, and the spinal tap or lumbar puncture. Researchers have found that the spinal fluid contains more protein than usual and less immune cells, which is measured by the count of white blood cells. However, it might take up to 10 days from the onset of the symptoms to develop. So within Guillain-Barre syndrome, there are 5 known subtypes that I will be explaining one by one. We're going to start with the acute inflammatory demyelinating polyneuropathy, and it accounts for 80 to 90% of GBA's cases in Europe and North America, and it's characterized by an immune-mediated attack on the myelin, as you can see in this picture. It's right on top of it, and these two right here are white blood cells that are meant to be attacking an infection or a virus. However, it sits on the actual myelin sheath. The most common signs of this subtype is muscle weakness that starts on the lower extremities and it works its way up. It does affect both motor and sensory fibers simultaneously. And the electrophysiology shows slow nerve conduction velocity and prolonged F waves. The second one is the Miller-Fisher syndrome, and it's a rare variant of GBS. It's observed about only 1 to 5% of all GBA's cases known worldwide. It's known for 2 specific characteristics. 1, the weakness and paralysis of the eye muscles, and number 2, because most of the people with MFS has a unique antibody, the GQ1B. In most cases, there is a complete recovery within 6 months. The third one is the acute motor axonal neuropathy, and it's more common in China and Japan as opposed to the Western countries. As the name says it affects the motor neurons, and it has early and severe respiratory involvement. It affects children and young adults. In this subtype, the axonal degeneration happens by immune attack within 1 to 2 weeks after the infection. So the macrophages invade the nodes of Ranvier right here, where they insert between the axon and the Schwann cells. So the myelin sheath stays intact. You can see in the pictures right in the middle instead of laying right on top of the myelin sheath. Now the fourth one and fifth one. The fourth one is the acute motor sensory axonal neuropathy. So it's almost the same as the one that we just talked about. The difference is that instead of attacking the motor neurons, this one attacks the sensory motor neurons. It's known for acute weakness of the limbs and respiratory failures. It does affect the cranial nerves, and it's known for the vegetative involvement. And the last one is the acute panautonomic neuropathy, and this one is the rarest GBS variant because it involves the sympathetic and parasympathetic nervous system. It's known for the postural hypotension, decreased salivation, lacrimation, and pupillary abnormalities. These arrhythmias are a significant source of mortality. Motor or sensory disturbances, and the recovery is very gradual and often it's incomplete. So let's move on to the therapeutic management. There is no known cure for Guillain-Barre syndrome, but it can be managed. So in the acute care, the 2 most common treatments are the high-dose intravenous immunoglobulin and the plasmapheresis known as the plasma exchange. Both treatments are equally effective to interrupt the immune-related nerve damage if it starts within 2 weeks of the onset symptoms. So the plasmapheresis, what it does is that it removes the bad antibodies that have been damaging the nerves. It's beneficial in shortening the length of the disease and lessening the long-term disability. In the IVIG, just to have a review, the immunoglobulins are proteins that the immune system makes to attack infected organisms. So this type of therapy involves intravenous injections of these immunoglobulins. The results can be a lessening of the immune attack on the nervous system, and it may be beneficial in the acute stages. Now, in the rehab care, as we know, once the patient is stable and it has made improvements, they're transferred to a rehabilitation setting, and they will receive OT, PT, speech, and nursing. The main things to keep in mind: we want to prevent contractures by performing range of motion, improve bed mobility to prevent bed sores, improve overall strength and endurance, resume participation in ADLs and IADLs, and they usually continue medications as blood thinners to prevent clots. So Guillain-Barré syndrome can have other serious complications that must be managed. As we talked about, some individuals might have breathing difficulties, and they are going to need respiratory support to breathe within the first week of the treatment. They're going to have residual numbness. They might have some heart or blood pressure problems. They are going to experience pain, bowel and bladder function problems, blood clots, pressure sores, and relapse, although there's only 3% of people with GBS that might experience this at any time. So now we can move into the prognosis of Guillain-Barré syndrome. 70% of people with Guillain-Barré syndrome make a full recovery. The point of greatest weakness occurs days to at most 4 weeks after the first symptoms. The symptoms can start stabilizing for a period of days, weeks, or even months. Full recovery can take up to a few weeks, 2 years. 30% of people with GBS will still experience some type of weakness after 3 years. 3% may suffer a relapse of muscle weakness and tingling many years later. 50% of people might experience long-term effects, so they're going to need the use of walkers, wheelchairs, or ankle support. Because this is a very sudden syndrome, people might experience emotional painful periods, so they will need psychological counseling to adapt, and the need of support groups. For that, there is the GBS Foundation. It's a worldwide organization, and within the United States, they have at least 75 support meeting groups throughout the year, so we can refer them to these support groups as well. They do a lot of research and to improve access to care and global awareness. So this was the presentation for Guillain-Barré syndrome. I hope you guys enjoyed and understood it. Post your questions and comments about this syndrome. Thank you. Here are my references. All right, that was it. Thank you.